Everyone, my name is Matt Mancini. I was planning on giving a little bit of intro. I forgot that Katie had some stuff to say, so I won't have a lot more to say about myself. I am coming to you live from my office, where I just kind of stayed a little bit late today in order to meet with you all. So thanks so much for joining. I know it's a Wednesday evening. Thanks for being here. I'm really excited. And before I forget, thank you to AAPA for letting me have the opportunity to talk to you all tonight. So tonight we're going to talk about how to PA like a primary care pro. I'm going to pull up my presentation here in a moment. But let's see, I do want to reiterate what Katie said, that you can and should put any questions in the Q&A. My email is on the last slide, and I am happy to receive emails and chat out more things that you have questions on, but I do strongly encourage using the huddle to post your questions. That way all can see and answer. But if there's anything that you felt like you wanted to just direct to me, I'll have my email on the last slide. So I'm going to share my screen here. Okay. All right, so as I said, we are going to talk about how to PA like a primary care pro here. And I put a little info about myself, but as Katie said, I guess just, briefly, I'm in New York City now. I have practiced in primary care since I graduated in 2016. I worked at a small primary care practice at first in Connecticut. And then I moved to Washington, D.C. and I worked for a larger practice, the GW Medical Faculty Associates at George Washington University. So I went from a small practice to a large practice, and now I work at One Medical, which, if some of you are familiar, it's a pretty large primary care practice as well that spans across the United States, and we are constantly growing in new locations. So I work out of the Rockefeller Center office in New York City. And as Katie mentioned, I was involved in student leadership, and I'm really interested in how students and pre-PAs can get involved and move the profession forward, because they are the point at which we have to kind of identify our future leaders, because that is where our profession is. So if you have questions about potential leadership opportunities, if you're a student, or even if you're just a pre-PA, and not just, but if you are a pre-PA and want to know more about ways that you might be able to get involved as a student, it would be something I'd be happy to talk to you about. So you can message on Huddle or email me. So I do not have any financial disclosures or any conflicts of interest in our presentation here tonight. What we're looking at talking about are the roles, responsibilities, and opportunities for PAs in the primary care setting, to review tips on primary care resources, job search, and interviews, and ultimately get you excited about primary care, whether you're a practicing PA who's maybe looking to change specialties or know a little bit more about it, or a PA student thinking about your rotation, or a pre-PA thinking about what you might want to do. I hope that you get some more information about primary care and get excited about it. Some statistics here are that there are approximately 159,000 PAs in the US, and literally growing every single day. And these PAs engage in greater than 500 million patient interactions per year. That's an astonishing number. The 2022 AAPA salary report that was released says that 19.83% of PAs practice in primary care, and that primary care PAs earn on average $110,000 per year. That, of course, varies depending on the geographical location that you're in, your employer. There's a lot that goes into that, but these are stats that came from the salary report. And if you're not familiar, it gets released with information that comes from PAs across the country in different specialties and in different states on salary and other kind of information that we'll talk about shortly here. And if you are an AAPA member, you have access to this information here on the AAPA website. So why primary care? I think that sometimes it can be, even though, like I said, 19% of PAs practice, sometimes it can be one of the specialties that's forgotten about, or not everyone even considers primary care a specialty. We might think of it as just the general practice out there, and everything else besides primary care is a specialty. But I'm really sad that I don't have all check marks on this slide. Apologies for that. I don't know why it did that, and I'm sorry if that's bothering you as much as it's bothering me. But why might you want to go into primary care? You totally build relationships with patients, and I'm sure that's something that maybe you know of or have heard people say before, but it's 200% true. I really like the ability to see patients again and again, and to be able to be someone that they become familiar with, become comfortable with, feel like they can say anything to. And you don't always get that in other specialties. If you are, say, in the emergency room or the ICU in the hospital, there are other things you get out of it. But in primary care, if you are interested in that, or if that's something that excites you, it is something that's really great about it. Also, this has grown since the pandemic, the opportunities that you have for both in-person and virtual care, which I'll talk a lot about, the ability to do adult primary care only, or family medicine, which includes pediatrics. You maintain your kind of general medical knowledge base, acute and chronic care management. So you get to do urgent care type of things pretty much every day, plus management of chronic conditions. And you do get variety in your day-to-day schedule. So I would challenge when some people might think that primary care is the same thing day in and day out, or that other specialties are kind of, you get a different thing every single day. I get a different thing every single day. I'm always challenging myself with a new patient presentation, something I don't know about, or just the variety on my schedule changes every day. I'm not seeing, all patients down my list for a diabetes follow-up visit. There's a lot of variety. The schedule for most primary care positions tends to be that kind of traditional 9 to 5 schedule that you might think about. But this really depends on the practice that you're working for. There are more and more opportunities these days, it seems like, for later shifts, like evening shifts, some weekends. Some primary care positions you will have to kind of commit in the beginning, I guess is what I'm trying to say, for weekend shifts or for an evening shift here and there. I don't work any evenings or nights doing patient care in my job. We work essentially like 8 to 5-ish. But at some practices, like at my very first one, I worked, I think, 2 weekend days per month or 1 evening day per week. So it depends on where you're working. There are virtual positions within primary care, and this tends to give flexibility for those kind of evenings and nights if you want, or even in some companies kind of creating your own schedule. I am not going to name any specific companies out there. However, there are more and more companies these days who are providing primary care solely from a virtual platform. There are also companies like where I work at One Medical who do a hybrid of in-person and virtual care. So I do both in-person and remote visits, and a lot of places are going that way. There are a lot of things in primary care that are going that way. So if you are excited about virtual patient care, then primary care could be a good role and an exciting role for you. Also, work from home is something to think about in the schedule of primary care. I would say that in general, my friends and colleagues who work in hospitals, this is kind of generally speaking, tend to do their charts when they are at work, maybe stay late until they're all done and then leave. In primary care, you either might stay late, you might decide that you're going to go home on time if you have to get home to dinner or childcare, et cetera. But then in doing so, if you have charts to complete, you may log into your laptop at home at night to do that, or on your day off or on the weekend even. Primary care does come with that kind of a necessity to work outside of the designated hours that you're scheduled. So something that's really important, I think, is what I mentioned here, which is called administrative time. I didn't really know about that when I was a PA student, or honestly in my first job. when I worked 40 straight hours of patient care per week and didn't have any time to, contact patients with their lab results, to follow up on x-rays or imaging studies, because all day, every day in primary care, you're ordering labs and you're ordering imaging studies and you're ordering referrals, and patients might be messaging you if you have a portal system like most places do these days. You really might want to consider a position in primary care where you're given administrative time, which is something I've had in my last job and current job. And I would say that I don't think I would ever accept another primary care position without potentially having built-in time to my schedule in order to be able to speak with patients, to follow up on things. So essentially, I work 32 hours of directly seeing patients per week, and that's my full time. And then my regular day off, we call it, is on Fridays. So I'm often working from home on Fridays, but I'm only seeing patients Monday through Thursday. And so that's built into my schedule. And I think that's something, if you're thinking about a primary care position or you're looking into it in the future, it'd be a good thing for you to talk to your future employers about, or something to come up when you're interviewing, to ask about the time that you as a PA in that practice would have to follow up with patients, and if there's administrative time built in. So this is just a kind of really rough mock schedule for what you could expect to see in primary care. And this would be, for example, a morning block. And this would be what I think a lot of PAs might do, which is a half an hour schedule. There are some offices that do every 15 to 20 minutes. That's something else that you might think about if you're looking into positions or interviewing, maybe, what the schedule is like in the patient blocks. So for my schedule now, I see a patient every half hour. It does not matter what that's for. It could be a physical, or it could be a pre-op visit, or it could be a skin rash. So sometimes you can make up time, if a physical runs over and is 40 minutes, then you see someone with the sore throat that only takes 20 minutes, then, you can kind of make it up. But for example, you might see wellness visits or physicals mixed in with remote visits, mixed in with acute complaints like a skin rash, a headache, an STI test or abscess drainage, a follow-up of a chronic medical condition like high blood pressure or diabetes. And you'll see that at some places like what I do, we alternate between in-person and remote visits. So my schedule is open. Each block, a patient can book in-person or remote. And essentially, if my next patient's on Zoom, I do what I can with my patient that's here. I finish up, I walk them to the front, then I come back here and I log into Zoom for my next patient. So let's talk about some common presentations that might make their way to you in primary care. One thing that we do see a lot of are physicals. In my job currently, we see up to 6 or 7, I want to say 6 physicals per day, out of a total of 16 patients that blocks on our schedule. So it's a pretty good amount. You would have, so to speak, a lot to do, but also you have to keep in mind what can be reasonably accomplished during the visit, and know that not everything has to be done during a physical. So we've kind of thrown out that old idea or notion that at a physical, you do everything from the top of your head to the tips of your toes, and all of the lab tests and all of the tests out there. You have to be a little bit more focused than that, and understand that what's not done at the physical can be followed up on another time. So you might be doing a review of their history, surgeries, medications, their family history that's contributory to them, what's important, social history, context, either physical exam. And then the really important part, I think, is what we call health maintenance. So that would be screenings for things like labs, cancers, depression, bone density, things that are relevant to the particular patient that you're seeing, vaccines. And something else that comes up often is acute issues. So maybe you know about this, or maybe we've even done it before. You go in for your physical and you say, by the way, I've been having back pain for the past few months. And then, as a primary care provider, we have to do what we can to either address these things during the physical, or, being good about making follow-up visits. So there's a little bit of juggling that comes up in primary care. It certainly always keeps you on your toes. And another thing that you might see quite often are acute care visits. So these are things for visits for anything like a sore throat, a urinary tract infection, back pain, a rash, anything that someone might come in for that they otherwise might have gone to even urgent care for, or even the emergency room. Patients will come in with chest pain sometimes that might be heart related, and it's up to a primary care provider or PA to be able to assess the patient and recognize that and know that just because the patient came to their primary care and not to the emergency room does not mean that it's not an emergent issue. So you do have to use your knowledge and skill set to be able to assess patients and understand that not everyone that's presenting in a primary care setting is going to not have something that's urgent. So in this case, you do a more focused history and physical, not like you would necessarily be doing in a wellness checkup, focused vital signs or medication review that might come depending on the staff that you have in the office. Like where I worked before, we had medical assistants who did vital signs and med review. But at One Medical where I work now, we don't have medical assistants. Actually, the provider does everything. So I walk up to the front, I get my patient, I bring them back, I do any vitals that I need to, review their medicines and do the visit, which maybe sounds like a lot, but it's a really nice flow actually. And patients really appreciate doing everything with their provider. And so it depends on the staff at the office as to what you're responsible for. And then coming up with your follow-up plan and treatment plan for the patient. You also do chronic disease management in primary care, including high blood pressure, cholesterol, diabetes, depression, anxiety, et cetera, et cetera, et cetera. So this includes medication review pretty much at every visit to know if your patient is taking all of their medicines or not. If they've been refilling them, that's a good sign. Labs as appropriate for what's going on for them, vaccines staying up to date, and continually updating their plan of care. So every time you're seeing them, updating what the plan is. And it just helps you so much so that every time you see them, you kind of know what you talked about the last time, right? And also pre-op evaluations. So we do, I would say, this is probably out of everything I've listed so far, definitely the thing I see the least when you compare to physicals, acute visits, and chronic management. But pre-ops are done by primary care. And sometimes you'll see patients who are your patients that you know and see a lot. And sometimes you'll see a patient that you've never met before and they scheduled with you because their primary care provider didn't have anything available that day. So it's definitely something that PAs are trained in and completely skilled and competent to do. We just have to essentially look at these patients, assess them, and what I mentioned here on the slide called risk stratification. So essentially saying what the patient's conditions are and what might impact their ability to go to surgery and hopefully be successful with that surgery. So we're doing this from the medical side, not the surgical side. So you review their info here, you do your focused physical exam, and this sometimes includes collateral with their specialists. If they have a cardiologist, you might need to potentially get on the phone with them to say, I'm seeing this patient for a pre-op, but do you have anything to add? I sometimes do find myself speaking with my patients' specialists when it comes to things like med management, if it's something they get prescribed by another provider, or in this case with surgery. So you are kind of that point person in primary care, right? I think a lot of us think of primary care as that kind of central, and then all these specialists on the outside. And the specialists often aren't always communicating with each other, but the patient is always usually coming back to their primary care provider. So it's up to us in the center to take what's going on here, and when it's important, relay it over, right? So if my patient saw a dermatologist who prescribed them a medicine for their acne, but they're on a medicine by their psychiatrist for their depression, and those medicines interact and aren't good together, but the dermatologist didn't know they were on that medicine, now it's my responsibility, once I know that the patient's on the medicines, to either have the patient follow up with them or to contact them myself. So you are kind of that gatekeeper, so to speak. And I personally kind of like that. I appreciate it. I'm type A in a way, I guess. So maybe if you are type A, then primary care could be good for you, but also even if you're not. So I said I was going to talk about virtual care. So that's what I wanted to do here. Primary care does virtual care, and virtual care can be primary care. These might occur with a clinician being in the office. They also might occur with a clinician being at home. Some online platforms have their providers solely working from home. Others have them working in both. We have both at One Medical where I work. So I'm typically in the office, like I said, seeing patients on Zoom here and there. We also have completely virtual providers who work from home. So this is something that if you're interested in, primary care is where a lot of PAs practice virtually. You can reach patients in low access areas, which is something that the PA profession has kind of, in a way, been built on and has had a lot of interest in, I think. It's more convenient for patients, whether it's because they're in low access areas or just because of their work schedule, honestly. Now, there are limitations, as I mentioned, about what you can diagnose and manage in a virtual platform, but I think that you'd be surprised with how much you can manage remotely. There are certainly times that I tell patients they have to come in person. I would probably estimate maybe 10 to 20% of the time I might tell someone that they need to come in, whether it's then and there or let's do this treatment plan. And if you're not better in a week, then you have to come back in and be seen in person. So it just depends on what it is and what you're comfortable with. But virtual care is something we've gotten a lot more comfortable with, especially during the pandemic. And I'm grateful for that, I think. So in this whole time, PAs have been at the forefront of that and showing how we can provide increased access to patients through our virtual care. So that's also been something that I've been happy and excited to see that PAs have kind of delved into this and shown that we can be successful at it. So this was an interesting statistic that I just saw as I was making this presentation, as a matter of fact, which is that in the salary report most recently, about 3 out of every 5 PAs, so 61.4%, used telemedicine in their clinical work in the last year. Now, maybe that's kind of obvious, but if you think about all of the PAs out there in various specialties, in the hospital, in the OR, it's a pretty large statistic there. And 87.4% of primary care PAs responded that they were using telemedicine or telehealth. So we were the most likely ones to say that. So as I mentioned before, if you are interested in virtual care, primary care might be the most interesting place for you. And this graphic here from the salary report just shows that utilization that I was just talking about with the 87.4% of primary care providers out there. And then other specialties, as you see, internal medicine, which use 64.5% telemedicine, and then pediatric specialties, surgical. I think in the surgical subspecialties, a lot of that was for, in my opinion, I believe, for follow-ups after surgery. I think that a lot of surgical follow-ups were done remotely. And then emergency medicine, I will be honest, I'm not fully certain. I haven't worked in emergency medicine during the pandemic, but I do know that telehealth has been used by emergency medicine providers for follow-ups. But yeah, I mean, even that 20% of emergency medicine PAs reported using telemedicine, I think even that's a higher statistic than I anticipated. So let's talk about what knowledge and skills you might use by going into primary care. So we think of primary care as the kind of general medical knowledge place. You do use a lot of your kind of fundamental foundational medical knowledge, and over time you build on that through your patient experiences and your own personal studies and research. I think it's important to know that you do not need to know everything. So you might think of it that if you're in a specialty, you have to know everything about that specialty, but then if you're in primary care, are you expected to know everything about everything? And the answer is no. You learn as you go along, you learn from experience, and you know where your resources are. So it is not something to shy away from primary care, to be overwhelmed or think that you have to know everything that there is. No one would ever expect that. We do see patients for pretty much every single complaint out there, as I mentioned here: derm, orthopedics, GYN, neurology, cardiology, infectious disease, on and on and on. And when you need to refer patients to specialists in primary care, you oftentimes build a network of people that you refer to. And then primary care does oftentimes give you the opportunity to expand your knowledge and skill set to wherever you find is kind of your niche. So a lot of times in primary care, you find that your interest lies in a certain place. I went into primary care because I didn't really know what I wanted to do. I was in my final semester of PA school, and I truly had no clue what I really wanted to practice in. I thought at first maybe I wanted to go into a surgical subspecialty, and then I was good at surgery in rotation, but I didn't really love it. And I didn't know what I wanted to do. And I thought maybe if I go into primary care, I'll figure it out. And here I am 6 years later, and I'm still in primary care. And I don't know, I think that's just, important to know that you can not know if you are a student out there, a pre-PA wondering, you don't need to know what you are going to do for the rest of your life when you are coming to the end of PA school. But once you are in primary care for a while, you also kind of, like I said, develop certain interests, and you have an opportunity to build your skill set and be a resource in your office or your practice for things like HIV management, hormone replacement therapy, sports medicine, ADHD diagnosis and management, weight management. These are all things I mentioned because they're things that come up in my practice personally, where not every primary care provider, MD, DO, PA, nurse practitioner, whoever, not every provider does all of these things, but certain people have a clinical area of interest. So I started HIV management maybe about 6 months ago, and essentially taught myself through a conference and my own personal research. I'm kind of currently starting to do hormone replacement therapy. We have providers who do sports medicine, and et cetera, et cetera. So you kind of figure out what you like and where you want to go with it, and the services that you then can offer to your patients. So the more that you manage and are able to do for them, such as these things, the more that your patients get out of what you can offer them. So, fact or myth, primary care PAs do not actually perform procedures. I feel like this sounds a little bit like a leading question, so everyone already probably knows where this is going, but it is a big myth. Primary care PAs do perform procedures. We are not in the operating room. However, we perform daily procedures essentially. So I would say that I perform a good amount of these. I kind of have a list here. So incision and drainage of abscesses. Patients often come to primary care. They sometimes go to urgent care or the emergency room, but they will often come to primary care, sometimes not even knowing. They might say, I have a pimple, on my arm or on my back, and come to find out it's a large abscess. So you will see these kinds of things in primary care. Cryotherapy for warts and other skin lesions, skin tag removal, skin lesion like mole biopsies, anal and cervical pap smears, contraception like IUDs and Nexplanon insertions, which are contraception that goes into the arm. So these are things that some providers do. I don't place IUDs or Nexplanons, but other PAs and nurse practitioners that I work with do them because it's an area of interest for them, like I mentioned on the prior slide. And also performing EKGs and injections, depending on where you work. So at my office, we typically do those things. Sometimes our RN or phlebotomist does the EKGs for us though. So some resources for your day-to-day practice, your peers. I would highly recommend that. I think that having a trusted system of people around you that you can ask questions to, they can ask questions from you, I think is just so important. You can really feel comfortable, I think, asking questions of people that you're comfortable with and know, and who you know aren't going to think that you're stupid to ask the question. You can also refer to some of these places. I do not have any kind of connection or affiliation with these besides that I use them in my day-to-day primary care practice, such as UpToDate, Epocrates, CDC website for travel. Patients, I didn't mention that before, but patients often come in for travel encounters in primary care. So the CDC travel website tells you all of the vaccines and meds that your patients might need to travel internationally. Also immunizations, like the immunization schedule for what vaccines your patient needs. And this kind of long worded thing at the bottom called the ACCASCVD, Risk Estimator Plus. That's a long-winded way of saying you get your patient's cholesterol panel back and you want to know, do they need to be on a cholesterol medicine or do they need to be on blood pressure medicine? This calculator online, you put in certain data points and it generates this number and tells you what's the patient's risk for cardiovascular disease. And that's something that I find I use a lot with my patients in physicals when I do their labs. And the primary care rotation for PA students. So sometimes you will see this labeled as a primary care rotation, a family medicine rotation, or an internal medicine rotation. And programs do sometimes use these interchangeably. But personally, I think it's important to know that if you're in a program that offers internal medicine inpatient in the hospital and not primary care outpatient, you are not necessarily getting that primary care outpatient experience. And it might be something to think about if you have an elective to do a primary care outpatient rotation, because I feel kind of strongly that all PAs and PA students should have exposure to outpatient primary care, not just inpatient internal medicine. So it might be something to think about in your PA program if you don't have an outpatient primary care rotation, or if you got assigned to just an inpatient one, to consider an elective in primary care actually, because I think it will give you good breadth and depth of knowledge, exposure to things like physicals, acute and sick visits, all the things I said before, medication management. It's a good time to kind of polish up on medications if you had pharmacology before, and also watch your preceptor maybe help perform certain procedures, like I said. You'll see both new patients to the practice that have never been there before, that have no historical context whatsoever, versus established patients that have information in their charts for you to go off of. And it's a great time to hone your physical exam techniques using your stethoscope and taking blood pressures. It's just kind of like the basics, and a great time to get to feel comfortable with that. And also just communicating with patients, sitting down and talking to them. And then this is a little case study here with patient MS, who is a 45-year-old cis male who presents to established care. He has no past medical history, but has also not had a primary care provider or a physical in over 10 years. So although he has no past medical history, we're not entirely sure of what might be going on because he hasn't been in for a while. And we see this often, and more so after the pandemic. He has generalized fatigue for the past 6 to 12 months. And I feel like I see that often when patients say how long what they have has been going on for. They might say, I think it's been 3 months, but I also feel like it's been longer. And then they'll give you a timestamp for a wedding they had a year ago, and they said they had it back then. So it's you have to kind of pull information out of patients sometimes and use your history taking. So we might ask other symptoms that he has besides the fatigue, medication list, and remember to ask about supplements, because some patients don't remember that or don't always think of that as a medication. Sleep history because of fatigue, we can't forget, that's a primary factor here potentially. Psychosocial variables like alcohol consumption, recreational drug use, smoking, occupation even, and what he's tried so far. It's important to understand that what you do might be based off of what has been done so far, kind of what has worked and what hasn't, So let's say that we do labs, and the labs show us that MS has prediabetes, mildly elevated liver enzymes, and a negative workup for infections, anemia, and thyroid dysfunction. This was a kind of general I put down. I could have put a lot more. I was trying to just be very brief here. And this is something we see often in primary care, these things like pre-diabetes, mildly elevated liver enzymes. And you kind of have to be a bit of a detective to use, your intuition and the lab results, and look at the patient in front of you and think what's significant for them, what needs to be followed up on, et cetera. And upon questioning further, MS admits that he's been sleeping an average of 5 hours per night. He started a new job about a year ago that requires him to be at work or on his computer for most of the day and evening. He has been stressed and anxious, but admits he was reluctant to disclose that information at first for fear that his fatigue would be automatically blamed on stress without further consideration. So I feel like this happens a lot. It's another thing I mentioned with kind of probing or history taking and needing to kind of gauge where patients are coming from and get information from them. They don't always say everything at first, and it's up to you to, again, be a detective. I really think that's important to understand, that a lot of medicine, and I think a lot of primary care, is being a detective and figuring out what's going on in this situation. So our plan with him is that we are going to schedule a follow-up visit to discuss options for stress and insomnia management. So kind of the point of this understanding is that not everything happens at one visit in primary care. You might talk for your 30 minutes that you have, but then, now the 30 minutes is up and your next patient is sitting in the waiting room waiting for you. So you need to understand your limits and be mindful of talking to patients about how you can follow up after that. So the good thing about primary care is we're here, not going anywhere. And so, the patient sees you today, whatever is not urgent, they can maybe see you again next week. You might want to schedule a physical if they haven't had one in a while, like MS, and encourage these regular visits to establish the relationship, and also follow up on those abnormal labs that we talked about and come up with a plan for improving those pre-diabetes and liver numbers. So then your primary care PA job search. So after tonight, I imagine you're all going to go on, I don't know, Indeed or whatever, and look for your jobs in primary care, which I'm really excited about. That'll be great. So this is just a little information for you all before you go out and look for jobs tonight. First, you should cast a wide net. This includes online job searches, like I just mentioned, using the AAPA or your state constituent organization websites, which have job postings. So a state constituent organization, for example, would be the New York State Society of PAs, the Connecticut Academy of Physician Assistants. So you, if you are a member, have access to these associations' websites, and they often have job postings there. So becoming a member of these organizations can be helpful in order to get access to those things. And also, if you're a student, running it by your professors or as a PA in another specialty or colleagues. And that's actually how I got my first position, was that one of my professors that last semester had mentioned to my class that her primary care practice was hiring a PA, and I didn't know what I wanted to do, like I said. And I said, you know what? I don't know, primary care, like, let me interview, let me see how it goes. And I liked the office, I liked the providers that I would be working with, and, you know, and now here I am, you know, in primary care still. So, you know, using your professors and their connections could be really helpful too. There are what you might consider barriers versus what you might consider opportunities. And those include experience and NP or nurse practitioner versus PA postings. So when it comes to experience, some jobs will say that they want a certain amount of experience, and maybe you have that, maybe you do not. And I would say apply anyway. And same thing when it comes to NP positions. If the position says primary care NP, go ahead and apply. I know PAs who have gotten jobs that way. You do not have to write it off just because it says that. You need to individualize your cover letter. I think that's really important. You certainly don't want to submit a cover letter for a primary care position that says, I'm so excited to work in surgery because, but also I think it's important even to make that little line in there where you say, and it could be just one line where you say, I'm so excited about this position in primary care. And if you're applying for different specialties, you just change that wording out each time. But I think that really individualizes it and makes you stand out. And also know what you're looking for. I mentioned kind of before, like adult medicine or family medicine, if you want to do pediatrics, what kind of schedule you're looking for, if you're looking for virtual care opportunities, and the geographical location. Interviewing, so remember that they're interviewing you, you're interviewing them. So they might want to know what makes you like or want to go into primary care. I feel like that comes up on most interviews. What experience do you have? You also might ask them, when and how do providers get their administrative work done? Like I mentioned before, do they have administrative hours? Do you find that providers are working from home on nights and weekends? And you might want to know that information. Also find out if it's possible to shadow a provider, because that tells you a lot about the job and the day-to-day workflow, and it might make a difference for you accepting the position or not. And that was it. I had hoped to end a little bit earlier even than this, because I really wanted to leave time for questions. But as I mentioned, please put them on Huddle if we don't get to them now in these last about 15 minutes or so, or my email is on this slide here.
Thank you so much, Matt. I think that was incredibly comprehensive. Let's start with some of these questions. What do you feel was the biggest challenge for you when starting out in primary care, and what recommendations do you have for preparing for this?
I would say that my biggest challenge was probably knowing that it was okay, what I said before, not to know everything. So I felt weird or awkward to ask a lot of questions by my collaborating physicians or my colleagues. But it's your first position. You don't necessarily know everything there is, and that's okay. So I think that knowing kind of what your limits are and what you're comfortable with, but also understanding that that's okay, is kind of crucial. And just know that everyone goes through that. There's that learning curve. I would say that it probably takes a full year to really kind of start feeling comfortable, and maybe up to 2 years to feel like you're just kind of, flying along. But that time comes.
Yeah, but I think this is a good question too. Is it ever hard to treat or see a patient who is non-compliant? And does it get to you emotionally?
There are definitely hesitations that you'll have, or maybe frustration. So there may be some self-reflection you have to do, right? Like, how do I feel about this and what can I do? At the end of the day, primary care is a partnership between you and the patient, and you do your part, but the patient has to do theirs. So I definitely am so much better about this than I used to be. And I would call patients on the phone in the evening time when I was concerned about them and they weren't answering all of my messages. Now I understand that they will follow up when they're ready a lot of the times, and you can only do so much. So you fulfill your role, the patient has to fulfill theirs. And at some point you will get comfortable with that in primary care or in any specialty, such that, you learn how to get by with that. And you understand that as long as you're doing your part, that's the most you can do.
I think you touched on these next questions a little bit in your earlier response about sort of getting more comfortable and getting up and running. But these two are about how, as a new grad, you were able, did you feel like you were in a position where you had too much autonomy? How long did it take you to feel like you were sort of confident and competent? And how does that the relationship with your collaborating physician work?
Yeah, those are really good questions. So my very first day that I showed up to my very first job, I had no clue what to expect. I showed up and they said, "You're seeing patients today by yourself." And I think I only saw one patient per hour. So I probably saw like 8 patients that day, but I really wasn't even expecting that. I thought maybe I would be shadowing the first day. So I feel like a lot of primary care positions can be like that. And you might feel a little bit like you're thrown in at first. However, you are trained in order to be able to do that through PA school. And so you will be able to. I definitely asked questions to my collaborating physician or colleagues on at least 50% of patients, I would say, honestly. I mean, it might have just been, "Hey, I'm seeing your patient for a sinus infection, and I didn't want to give them an antibiotic, but I think I had to, and they had an allergy. What do you think about this?" Or it might be, "Your patient that you've been seeing for high blood pressure for years and years and years came in to see me today, and I don't want to disrupt what your plan was." There's lots of things like that. But I would say the first year I did a lot of that. The second year, like the year 2, less. And honestly, ever since then, I rarely speak with my collaborating physician about patient issues or like needing help. I think that around year 4 is when I really felt like I was more or less autonomous in my day-to-day, being able to see patients and not needing to run things by anyone, which is how things are. In primary care, we don't have, just like everywhere else, we don't have a physician or someone over our shoulder seeing the patient with us. We're doing everything for the patient then and there.
I think that's helpful. I think there was one more follow-up about the collaborating provider. Can you just describe a little more about how that works?
Yeah, so as PAs, a little bit of this depends on what state you're practicing in, but you are paired with a collaborating or maybe supervising, depending on the state, physician who may be required to do various tasks with you. That might include co-signature of charts in some states. It might include a quarterly meeting. In my position currently, it just includes the quarterly meeting. My last job in DC, I actually had to have all of my charts co-signed, every single one. That's not a DC law, but it was a practice rule. So it kind of depends on the state and the practice you work for. But essentially you have someone that you're paired with that you can run things by. They only need to be available mostly in most places by electronic communications these days. So they don't need to be even physically in the building in a lot of states, but it's also state dependent. But a lot of places like in New York, they just have to be available by text or email or Slack. And so you have someone to ask questions to, and sometimes you have to do a quarterly meeting with them where you just meet up and say, here's how things are going. I'm good. I did mine just last Friday, actually, with my collaborating physician, and we kind of chatted it out and how things are going. Yeah.
We and I can't recall this in your background. Have you, we have a couple of questions about working in community clinics versus in, more of a full, not the word isn't right, normal, but a private primary clinic versus a community clinic. Do you have any insights about that?
Yes, I just want to make sure I'm understanding that. Are we asking the difference between the two?
Yeah, one question asked the difference, and one just wanted to hear more about working in primary care in a community health center.
I gotcha. So the main difference that I've found with working at a big practice versus a smaller practice is like the referral network, like how to refer patients. You might have a system that you work with that might be easier to refer to, versus at a smaller practice, you might just have kind of literally like the GI down the street that you send patients to. It also might be a little bit easier to have kind of protocols in place for how things work, or labs like on site at a larger company than at a smaller private practice. Sometimes at a smaller practice, primary care PAs might be a little bit more responsible for more of the hands-on things, whereas sometimes in larger places, there are more likely to be medical assistants, et cetera. That being said, like I said, we're a big practice, big system, and we don't have medical assistants, but it kind of depends. That would be kind of generalization. I cannot speak to primary care PAs in community health centers since I have not worked in one myself. But whoever asked the question, if you would like to put it on Huddle, we might be able to find someone, or if you email me, I can connect you with someone who works in one.
There's a couple of questions about charting and whether primary care has more charting than other specialties, and any other insights you have particularly on charting. There's a couple of questions about that.
Yeah, absolutely. It is a little bit of what you might say could be like the bane of some primary care PA's existence. So I know where these questions are coming from. I think that it might be a little bit institution dependent, but where I work now and the last place I worked have been very big on trying to cut back on provider burnout. And one of those is cutting back a little bit on unnecessary charting. So a lot of providers and a lot of PAs tend to overchart because you don't want to do the opposite and underchart because of legal ramifications. However, most of the things that we put in a no is overcharting, and I'm very responsible. I know that, like, whatever you want to say, I'm cognizant that I overchart. That being said, overcharting leads to you needing to work more outside of your clinical hours, and that's not good either. So you need to kind of come to a common place where you can get the information down for legal purposes, like anything that you did that's important for that patient's situation, and cut out the things that are not relevant. And it takes time and it takes practice and experience to get to there. But that is important. It's also good to know that primary care PAs, yeah, we do maybe chart more than some specialties, but I think back to my internal medicine rotation in the hospital and like seeing them chart in the ICU. And those notes were long, like every single problem, with the hashtag and the problem and the long list. So there's a lot of charting there too. Granted, we're doing we're seeing maybe 16 patients a day and charting on all of them, but you need to just balance what's important for legal purposes versus what's overcharting that you can get out of there.
There's a couple of questions about burnout in primary care. Some want to know if you think there's more stress in primary care than other areas, and others just want to know some advice for managing burnout and staying fresh in primary care.
Yeah. I don't know the statistics on burnout by specialty. I'm sorry that I can't answer that, but I would say it really is as dependent on where you work and your happiness and content with what you do. So I think that's as important as the workflow issues like charting, for example. If you work in primary care and have this charting and I don't know, let's say that you stay an hour late every single day or whatever, and your peers get to leave on time. If you like what you do and you're happy and you feel fulfilled with seeing patients, that's going to prevent you, in my opinion, from getting burned out. I've felt burnout in prior jobs. I don't feel that way where I am now, even though I do work outside of my clinical hours. So I think it has a lot to do with where you work, how you like where you work for, and those things that bring you fulfillment and liking or loving what you do. But if you have reached the place where you feel burned out, then I think it's important to ask, for example, in primary care, do you have administrative hours? I think that the people who are more likely to burn out are the people that don't have administrative hours, because you need time. If you're seeing patients 9 to 5, Monday to Friday, when are you going to message them? When are you going to call them on lab results? You're getting messages, if you have a portal system, when are you going to respond to them? So it's really important in that case to talk to your employer about administrative hours and when you have time to do that stuff, or considering either cutting back on your hours if you can in certain ways, or changing your schedule around, asking if you can have a break in your schedule. Like in my job, we have the option to do something like, say, see 4 patients, then take like a 10 or 15-minute block, then see 4 patients, etc. So some places are good with working on your schedule and kind of accommodating your requests for how you want your schedule to look. Or, as a PA, you have the option to move around. So if you're interested in a different specialty, you can go that way. If you're interested in primary care, maybe you're interested in virtual care. I think some primary care providers, PAs and others, might have gotten burned out during the pandemic in person and moved to virtual positions. I've seen that a bit, I think. And it kind of just gives you a different vantage point, working from home a little bit different. And maybe one day some of those PAs will return back to in-person work, but it's a nice, good alternate, like I mentioned, that you can still work in a similar situation in primary care.
There was a couple of questions around payment and reimbursement. Do you have any insights around how primary care PAs get paid? What typical salary structures are like, things to kind of look out for, especially as these new grads are going into these negotiations, models of payment.
I can speak to that a little bit. I only have the experience with where I've worked, and it's very, very institution dependent. Primary care PAs are traditionally salaried and oftentimes do not have an RVU structure, whereas urgent care or emergency medicine PAs, et cetera, might have RVUs, meaning essentially the more tests that you order, the more you might get compensated, because that kind of, in a way, you might see it as going against primary care. Like a patient comes in with a cough, so you might be more likely to order a chest x-ray because you get reimbursed more for ordering a test. But at the end of the day, in primary care, we want to try to do what's best for our patient, and not just what makes us more money. So our views are good in a lot of ways, and I'm not against them. And if I worked in urgent care or emergency medicine, I'd take the extra money. But in a primary care setting where we're trying to not do unnecessary tests for our patients, I think that there's a reason we don't often have our views in primary care, but it's something that you might find at certain practices. But the pay structure really kind of depends on where you work. It's important to kind of talk to your potential employer about things like, vacation time, obviously, what the salary structure is there, and considering talking to them about what it looks like with yearly raises, just knowing that you have to be a little bit careful about asking that question, or delicate, but it might be important to know, because if the providers don't typically get a yearly bonus or increase, that might be important to know, versus maybe if you start out making a little bit less than what you thought you would, but you know that there's a good chance you're going to get a raise the next year, then it might help you make your decision.
Great. Well, we are right at 8 o'clock, but I'm going to lob one more question at you, and it's kind of a big one. It came in a couple different versions, but there were a couple questions about sort of the perception of a PA versus a physician. Do you have, it sounds like you work pretty autonomously. Do you get feedback from patients that they might rather have a physician? And at this stage in your career, 5 years down, are you glad that you became a PA?
So the answer to that last one is yes. And by the way, in case anyone is dropping off now because it's 8, thank you very much for coming, by the way. So I am very glad that I became a PA. I think that all of the things that I've gotten to do, I not necessarily would have, gotten in other specialties, like getting involved in leadership and student leadership, and I don't know, getting involved in the profession. I think that it's really cool that we have opportunities like that in this profession to do that. There are obvious, differences between the various providers that might work in primary care or other specialties. And I think it's important to kind of gauge early on what you're interested in. So if you feel very strongly about the, MD route or structure, then I'm all for that. I think that if you're interested in medicine and you want to form relationships with patients and hopefully be content with what you do, but also have the opportunity to change specialties and not have to do the same thing for the rest of your life, the PA route is built on that. And I don't know, I've been doing primary care for 6 years now. I want to get into education administration of some kind. Eventually, I don't know, what's involved in the future, but it's just amazing to know that if I wanted to, theoretically, I could go into orthopedic surgery tomorrow. I'm not going to do that, but, dermatology, plastic surgery, pediatrics, whatever I want. So it's really cool that we have that option, whereas physicians don't, and nurse practitioners often don't, just because of the way that their training is, although sometimes there is that ability. So that only answered partially the questions that you asked, but I'm also not sure the remainder of the questions that there were. If there was anything else, let me know and I'll answer it.
No, I think that was a great note to send off. And I was like, this is the closing question, but a tricky one.
Yeah.
So I appreciate that. I think the rest of these questions are awesome, and we could sit here all night and answer them, but I'm going to encourage everyone to join us over on the huddle. Bring your question over, and we'll have, like I said, we have about 6 primary care PAs in different areas who can help us answer these questions, and we'll get them answered in the next week. So thank you so much for your time, Matt. I really appreciate how generous you always are with your time and energy, and I've appreciated this session quite a bit. So thank you and have a great night.
Thanks for joining, everyone.